Next up is Dr. Thomas No, one of our local faculty, neurosurgeon here at HPH System, and he'll give us a talk on technology and spine surgery, AR, and surgical navigation.
All right. Hello and good morning. As you can see, I'm all equipped for my talk about AR. This is a HoloLens 2, in case you're curious. And so I'm going to be gathering a couple of things, so give me a second. I've got to find where I left my, oh, that's funny, my screens are actually back there, believe it or not. So I literally left them over there. See if I can grab them. Okay, this isn't working. I have to actually literally walk over there. Now, let me do this. Hold on.
You want insurance for a fall.
This is a new thing, by the way. I haven't done this before, so I was trying to do something a little unique here, so just bear with me for a second. I don't know if anybody here has used a HoloLens before, but these are kind of neat things. You can use your finger to kind of tap and work on different things, or you can actually go up to whatever you're interested in and actually tap on it. So that's what I'm doing right now, just to make sure that I pull up the right presentation. Okay, and I don't think you guys can't see what I'm doing. This is a separate presentation here, so. Yeah, yeah, sure. Okay, all right, so.
You're doing when you don't have a glove on or something.
It just recognizes the tip of my finger.
How does it do that?
Yeah, so it recognizes both fingers and, yeah, and so
It's bionic, I guess.
Yeah. Okay, well, thank you for the opportunity to present some of the work actually that I do in my lab here. So we're developing better tools to do better surgery, essentially. We're going to talk about AR today, obviously, and how this can advance our ability to do spine surgery. I want to apologize in advance if this is very basic science-like. You know, in neurosurgery, there are these lectures where we talk about GBMs and tumors and things like that, and tumor markers. So hopefully it won't be as boring as that, but we'll go over some of the computer science behind this. And so I do have a grant for some of the work that we're working on. So, okay, so I'm going to grab this and try to pinch it, see if that, oh, look at that. Okay. So I will be talking about AR in spine surgery and some of the different FDA-approved modalities. We'll be talking a little bit about some of the work I do in my lab around registration and accuracy. And then we'll talk a little bit about some of the future applications for AR and where some of this stuff might take us in the future. So we can't really go too much into this without talking about AR, VR, MR. I think the distinction is fairly clear up here in some of the videos, hopefully they play. But the idea is that, you know, VR is essentially purely virtual. In other words, you don't interact with your environment, whereas with AR, and actually more appropriately, MR, mixed reality, are the modalities where you get to interact with your environment. So this is a prototype of actually the first type of VR that was, or AR actually, that we used. And this was actually by a group out in Germany. This was around 2011. It's a very basic thing. It's basically just one of the first prototypes that was ever created. And it's basically a PC tablet that sits and provides a screen. You have a reference marker that was on the patient, which was then all scanned together. So that whole piece was scanned together with the patient. And so the structures that you see, those have to be individually segmented. So that means a medical student or a computer scientist or somebody like that has to sit around and actually go pixel by pixel to segment each of those things, because they didn't have automation at that time. And then they had to superimpose that onto the video stream, which you can't see too well here, but in the paper they actually show it. And it's interesting. It's actually better than you would expect for something that was very crude. And now this is obviously developed into this, which we have 4 different FDA-approved platforms for intraoperative AR. You have Augmetics with their X-Vision, Novarad, which actually just got FDA approved with the Viz-AR. Medacta has a version of this that is a little bit older, but not as popular, I think, for some reason. 'Cause I've actually never used it before. And then SurgeLine has a window that they have that's called the Holo Portal. So each of these has kind of their pros and cons. We don't have enough time to go into like each of these different modalities today. But I wanted to discuss some of the evidence around just AR in general, even though there isn't a lot. And really the use as it compares to neuronavigation, particularly what we traditionally have in the OR that we use at least now if you are not using AR. So what exactly does AR add to our navigation? Well, in neuronavigation, there's a line of sight issue. So you're constantly having to, I hate to say this, but it's always like making sure that they can see your balls, right? That's what they always say. And then in AR, you have an integrated line of sight because you're always looking at the patient, and so that's your frame of reference. Attention shifting is a big thing, so this is probably actually the biggest advantage to AR. In neuronavigation, traditional neuronavigation, you have a screen that you have to constantly look away at, whereas in AR, there's essentially no distraction. The OR space, the space for any of these neuronavigation systems it's a significant footprint in the OR. As with AR, there's obviously just a headset like this, and except for something like the Holo screen. Trainees, this is actually a very interesting one because there are programs that are already offering their residents AR capability while they're in the operating room, and so instead of the trainee, and you guys have probably seen this, looking at the surgeon or at their attending, looking at the screen, looking at the pointer, going back and forth, and having to go all around, they're able actually just to look at the surgical field and actually see everything that's done all together. And that's a huge advantage if you ask any of the trainees. Thoracolumbar pedicle screws, the accuracy is fairly close. I think the main thing that they wanted to show early on were sort of equivalency studies, which essentially are pretty good. They range anywhere from 94 to 98%. And then in the realm of drawbacks, there are a number, and I'm not going to go into all of them, but there's still a lot of work to be done very clearly, at least as it pertains to AR. I think some of the challenges that we're facing within AR, they essentially just back to the traditional neuronavigation literature, which is surgeon movements, things that can occur when there's force applied to the spine, for example. This is just because it's unique sort of to the nature of spine surgery. In neurosurgery, the head is usually fixed, and so there's not a lot of movement, but you have things like brain shift, whereas in the spine, it's flexible and moving. So you do worry about that, particularly if you're doing things like osteotomies or correction. And then registration errors can have devastating consequences. I think we've probably all seen or heard of a navigation case gone wrong, particularly maybe a robotics case where you're basically just shooting on blind faith right into the spine and miss. And so, inaccurate surgical tools essentially can make, the adaptation somewhat cumbersome sometimes. And so there's all of that, and then there's the actual user interface issue. So, to give you an example, we just submitted a paper actually on resident opinions about actually placing ventricular catheters. So it turns out, the vast majority of residents around the nation, they actually don't use any image guidance for their EVDs. And so EVDs, ventricular drains that are needed particularly for pressure buildup inside of the brain or a number of other things can be kind of challenging sometimes. And if, for the neurosurgeons in the group, we all know there's always the M&M case of the resident who missed and, went off to the side, or it took him many passes or something like that. And so we know, unfortunately, that we miss about 40% of the time. And it's because it takes a lot of, training and and even with training, there's still the chance that you're going to miss, particularly if the anatomy is not good. And so, why aren't we not using image guidance for this? And it turns out it's because the amount of time that it takes to set all this stuff up. And so when you ask all the residents across the nation, how much time would you, use, or how much time would you allow for image guidance? It turns out it's about 6 minutes. So So getting the user interface portion of your program is incredibly, incredibly important. And so, what are we moving towards? Well, I think there are some new variations, which are very interesting. And I think actually this is a good example. This is Dr. Patel. He's out in Orlando. He actually, I think, does some of the image-guided technology for NAS, or is on one of the committees, I think, for that, or actually leads it, I think. But he's actually developed this sort of like Google Glass type of solution, where the only thing that he adds actually to his vision is just a screen, essentially. And it's a screen that fits over his loops. And it's very ergonomically smart because a surgeon, you think about it, doesn't want to take off their headset to put on a HoloLens and have to look into the field and do all this work. And it takes a bunch of extra time to have to get all that stuff set up. And so it's this benefit of being able to essentially slide something that's very ergonomic right over the top of your glasses or your loops, particularly for people who like using loops. Obviously, if you don't use loops, then you really don't care. But that is a consideration, and so it's going to be, I think, small incremental changes like these that kind of help to push AR to the next level. And so, one of the challenges I think that keeps surgeons guessing, particularly during one of these navigated cases, is the big question of accuracy. There's the problems of fading accuracy the further you get from the reference array. There's iatrogenic things that happen, shifts that occur during surgery. You hammer on the spine, you happen to bump your reference array, all those things. Long story short, anybody who's worked with navigation, you learn very quickly that you need to continuously vet and sort of question the accuracy of a registration. And so, some of the things that we're working on, this is a solution basically where we're using essentially a 3D slicer. This is an open source NIH-supported platform for computer vision research. And we basically have used a depth camera and are finding ways to adapt this to this type of technology where you can essentially achieve rapid registration in both, for both the brain and the spine. Yeah, so those are both playing good. Okay, so on the left side you have obviously a face that's being monitored by the webcam, and then the MRI that's fused to the face that's then following essentially that. And you can use any DICOM data for that. On the right side you have an example of this basically using a webcam and essentially a marker that provides a constant reference for AR tracking. I don't think we have the other video up, do we? The one with the him holding up the spine. So there's another video that isn't loaded up there, but he's basically holding this 3D printed model. We have a 3D printer system in my lab, but basically we take, he's holding up this model, essentially showing you that you can track this image on the spine. This is another type of what we call object pose estimation that's actually had some recent advances where basically you can eliminate objects that that have problems around them with getting a good image. So for example, if you're deep under the water, if you're deep into a surgical field, there's lots of blood, and what it does is it actually takes a sort of real image, a synthetic image, and then it's deep learned to create sort of powerful technology that allows you to estimate essentially what you're looking at. And the estimation is very, very precise. And so you can see here, for example, they're just looking at some objects on a table, but you can take technology like this, fuse it with the things that I was just showing you to give you a pretty good registration with good accuracy, all within the field that you're looking at. Last thing I want to talk about real quickly is just WebXR. It's another fascinating development. It's quickly gaining popularity in the world of computer vision and AR. It's WebXR. So essentially, there's no app stores, there's no large downloads where you need to patch in new software and all this other stuff. It's essentially all the same thing, and it's all online. So developers can basically develop without having to push, new code or, figure out if this is compatible with the next platform, et cetera, and you can use it on anything. You can use it on HTC, Magically, HoloLens, Oculus, and this is Steve. Steve Piper is one of the computer scientists that I work with, and he essentially developed 3D Slicer, but he's tracking an Android cell phone, essentially just using his a browser, like a Chrome browser, on his Android. It basically uses JavaScript on the web page. It's hosted basically in 3D Slicer, and so then the data, all that information is basically sent back to the server as URL parameters, basically just a link, and then they update basically the linear transform and give you tracking essentially live. And this is all done over the internet essentially. So there's no fancy chips or anything like that that are required. And if you wanted to, you could display this stuff. And we're using some of this to try to update some of our sequences for neuronavigation that we have going in the lab. So where are things headed? I think people have been using AR now for almost a decade, and we've been kind of messing with it to do a wide variety of things. And this list essentially keeps growing every year. I think future applications for this, we're going to have a lot of different things that we need to work on. An accuracy score that essentially reflects, the ratio of the screw that you use to the particular size. Those are things that need to be considered when we're actually talking about research and how to assess the accuracy of these things. And then all the list of things that you see there, everything from the hospital stay, how much this is versus traditional navigation systems, the amount of time that's spent in surgery. And then other things, kind of like I mentioned before, about the time that's required to set up the system. You get the scan, you have to plan, you have to verify and do all those things. And then even beyond that, as you move towards doing things that are actually intrinsic to the spine, osteotomies, tumors, we do start moving into that realm. You'll be able to probably segment those things and then see the tumor as it's chipped away while you're doing your operation, or even things like deformity correction. And even beyond that, there are people that are already actually sticking stickers onto the backs of patients and then using those to essentially track and use those basically as sort of like a reference array, the little spinal clamp that you use. And this has eliminated the need basically for the spinal clamp, and there are people that are already doing this. And this is stuff that works very, very well. They're basically using QR codes. And so that's the technology is definitely there, and so there's lots of room for improvement for a lot of the things that we already have, and I think this is going to develop rapidly over the next 5 years even. And then this was a cool thing that popped up in my feed the other day. It was basically just contact lenses where they inject an AR field basically into the contact lenses. And this all goes back to the same idea of WebXR, right? So WebXR, if you're taking information directly from online and you're injecting and going back and forth essentially just over the internet, this is something that maybe everybody will be wearing, and someday might be a way that you get your navigation injected into your eyes while you're operating. Shameless plug here. This is just an AI survey. So if you are a neurosurgeon, sorry, orthopedic surgeons. I don't know how many neurosurgeons are here, but if you're a neurosurgeon, this is an AI survey that if you could take for just a friend of mine in Italy. It's an EANS approved survey. I just want to put that shameless plug in there, but otherwise I'll take questions if there are any. Yes.
So where is it now? What are you capable of doing at this point? So for example, for the navigation, you take a spin, you look at the screen. So is the AR now overlapping that 3D screen that we look at with navigation, for example, onto the patient?
Correct.
Deep or?
Exactly, yeah. So if you ever try any of these platforms, it's actually really nice because it's all within your field of view. So you're looking, you don't have to avert your gaze. You're essentially just looking down at the patient and not really moving. You have your screen essentially in front of you so that if you're looking to see in your sagittal plane, your coronal plane, whatnot, where are you?
But what I'm trying to say, is it like a separate screen at the corner of your vision?
Correct.
Or is it actually overlapping the actual anatomy? Like
So sorry, it's both. It's so what it is that they give you an injection into your perspective. So you do have to calibrate. There's a calibration step, but once the calibration is done, you can actually see the anatomy underneath. And so for example, if you were interested in seeing where the facet was relative to your TP or something like that, then you'd be able to see all that within your field of view. And this is the other thing about it, is that we could sit here and talk about it all day, but until you actually go and try it, that's really until that's when you really realize kind of some of the value with some of this
I'll
stuff.
wear this goggle in a bit.
Yeah, sure, you can come up and try it.
Or maybe if you have it at lunchtime, we can, people can
And
test
play
it
with
out.
it, yeah. Just don't break it, please, it's not mine, so. Okay, thanks.